patient always need additional radiochemotherapy?
Thank you very much. Briefly, my disclosures. So at ESMO, there was a talk by Bruce Minsky. Chemoradiation is the standard treatment for locally advanced, clinically resectable T3 and or N+ rectal cancer. And I respect Bruce Minsky entirely, but I don't entirely agree with that statement. I was at an Estro teaching course last year, and one of the speakers said, we used to give preoperative radiotherapy, 20% pathological complete response rate, but there are concerns about acute toxicity, poor overall compliance, there's more surgical morbidity, no survival benefit, and we've abandoned it. I can see from your face a few of you don't think that's great. Well, he was talking about non-small cell lung cancer. So what's different? Because you recognize that a lot of those features are the same. So what's different? Well, the survival's better, there's less metastases, local recurrence is a bigger issue for rectal cancer. Radical surgery is probably more effective and less toxic. It's possible, as we've got Angelita Habragama here, it's possible to see and feel if you've got a complete clinical response for the low patients. And there are emotive issues surrounding a permanent stoma. The point I want to make is that we do need to think about what we are trying to achieve. So I guess the questions are, which patients with T3 cancers, clinically based T3 cancers, can you safely omit chemoradiation? Which patients always need it? And I'll address those a little bit. I'm not really going to address those other two questions that lead on from that, and which I think Dirk addressed partly yesterday. Which patients can you replace chemoradiation with chemotherapy alone? And which patients are, and that's a real sort of shot in the dark, I think, which patients might be better served by chemotherapy alone than radiotherapy. So, I was looking for something the other day, and I found this quote from Martin Fisher. I'm not sure why the tiger's there, but a good teacher must know the rules, a good pupil the exceptions. I'm going to certainly talk about some of the exceptions. So, as I said, the accepted wisdom, and you go onto the NCCN guidelines, every patient gets chemo-rad, every patient gets post-operative chemotherapy. I don't know where the evidence base for that is, but that's what their guidelines are. And the rationale is that there are low rates of local recurrence, you can get potential for sphincter preservation, you can allow integration of chemotherapy, and there's acceptable acute and late toxicity. Well, I'm going to address some of those. I'm going to leave local recurrence for a second, but I'm going to go and talk about sphincter preservation. Jean-Pierre discussed this yesterday. Meta-analysis and systematic reviews do not show that you will facilitate sphincter-sparing surgery unless you achieve a pathological complete response. And I can buy into that. So I do not think that the evidence base is that routinely chemoradiation achieves sphincter-sparing surgery. So I'm going to cross that one off. What about integration of chemotherapy? Well, I don't think any of these schedules is what I would call systemic chemotherapy. They're not what I would endorse for treating patients with metastatic disease. And the German study, which Karen Haustermans yesterday showed, is the only study where there is a benefit to the addition of oxaliplatin in some of the short-term endpoints. I think that really reflects that the control arm is a very poor control arm compared to what we think of today in terms of the chemotherapy. And none of those regimens, particularly as it's only 5 weeks, I would call systemic chemotherapy. So I'm going to cross that one off as well. What about acceptable acute and late toxicity? Well, again, Karen Haustermans talked about that yesterday, so I don't need to go into all these things, the fecal incontinence, urinary incontinence, sexual problems. I am seeing more insufficiency fractures, I have to say, in my practice lately, and there's also the question of second malignancies. Now, Karen quite rightly made the point, and I think others did, that current radiotherapy with IMRT and VMAT and things may be much more sophisticated, we may be more accurate, but I don't see any indication that we are getting any less toxicity. In fact, I sense that we're getting actually more small bowel toxicity because we're spreading around the radiotherapy more widely, and I'm seeing a lot more low-grade, late toxicity in terms of small bowel effects with IMRT. So I'm not at all convinced that that's going to improve the acute and late toxicity. So I'm afraid I'm chucking that one out as well. So back to local recurrence. So do we have such a small vocabulary that local recurrence, that's all we have to take account of? That's all we have to think about? Is the risk of local recurrence trump everything else? Trump function, trump second malignancies, trump metastatic disease? That's all we have to think about? And if it does, how big does that local recurrence risk have to be before we start thinking about not using it? So, we all know that local recurrence depends on lots of different things, all kinds of aspects of the patients. If you're a bit portly like me, you become a more difficult patient, and my risk of local recurrence would be a lot higher than some of the more slim patients. The tumor itself, which we can actually image on the MRI, the location, the position there, the extent, the aspects regarding the circumferential margin, the ease of resectability, which partly you can predict, that goes into the mix. And there are innate characteristics, molecular characteristics of the tumor. We talked yesterday about mucinous tumors and signet ring tumors, which I have a very bad feeling about. And the surgeon has a big influence. It's how well he's prepared with the MRI. How good is his roadmap to look before he operates, and how good is the quality of his surgery. I accept we talked yesterday about the quality of surgery not being the complete, the mesorectal quality of the mesorectum is not perfect as an endpoint, because you can do a perfect TME and still have a positive resection margin. If you don't have an MRI beforehand, that's likely. Also, even the best of surgeons are never going to do 100% perfect TMEs, because there are difficult, advanced, fixed patients. So that's always going to be the case. But in 2014, I mean, Karen Hausterman said, yeah, the radiotherapy is better. So is everything else when we're looking at local recurrence. In 2014, I get this. None of those trials that Jean-Pierre talked about as the evidence base, none of those had good quality TME that I look at in my MDT every week. These are the kind of things I see, and this. So I see the quality of the surgery. I see how good that operation was, and I can then fix myself into the next patient that's going to get. How good is that surgeon? How good is the quality of that surgery? So I think it is very important, the quality of the mesorectum. It's a bit of a busy slide, but if you bear with me a moment for this, you'll see in the top line, this is a Swedish rectal cancer study. Now, very few patients at that time had TME. And so if you look on the right, the actuarial risk was about 30% for no TME, or effectively no TME. The two studies that then thought, does short course compensate if you're doing TME, the Dutch study and the CRO7, only about 50% of those patients are assessed to have good quality TME. And in those studies, you're talking about 10% or 11% having a local recurrence risk. But if you take the patients who actually, all those patients in CRO7 who had good quality TME, according to Phil Quirk's assessment, then you're down to 7% at 3 years. And don't forget, those patients did not have MRIs on the whole. So even though you had good quality TME, you still had about 9% with a positive circumferential margin, which you should be able to exclude those patients. They shouldn't have a positive circumferential margin if you've got an MRI, which will then downstage some of those patients. You take them out. And finally, in the Mercury study, which does have some of the best surgeons in the world, I have to say, but in the Mercury study, where patients had good quality MRI, good quality TME, you're down to 3% at 5 years. How low do you have to go? So I was in Spain recently trying to explain the concept of futility. And they don't really have a good word for futility. But to the Y chromosome, futility is dusting. Okay, you dust, and the next morning it's there again, and you dust. and the next morning it's there august. So that's my definition of futility. So where does the level of futility come? Decreasing local recurrence from 10% to 4%. That's a number needed to treat of 16. Decreasing local recurrence from 6% to 2%. Number needed to treat 25. Decreasing local recurrence from 4%, which you will get if you've got good quality surgery and MRI, down to about 1.5%. Number needed to treat 40. You will know from your MDT, you'll know your recurrence rates and things. You will know where you put yourself there. Where does futility lie that you're going to expose all those other 40 patients to all the side effects, acute and late, of radiotherapy? And if you don't give radiotherapy these days, our experience is that the majority of those local recurrences are not outside in the sort of pelvic sidewall. They're often central, anastomotic, and you can give chemoradiation, and you can salvage about half of those with good surgery. So I really do wonder about the overall, every patient has to have chemoradiation. So what's the evidence base? Subset analysis. So we do have some data on upper rectal cancers. Some of the trials show benefit, some of the trials don't. The only study that has really confined itself to T3 cancers was the Australian study. So they were all intended to be T3 cancers. But when you look at the study, I'm not sure that the staging was actually that great, because even after short course radiotherapy, 44 of those were downstaged and 8 of those were upstaged. So 33% of the patients probably were not actually T3 in the first place. The MRI, it doesn't tell you how many of the patients actually had MRI, or the quality of the MRI, which I suspect back in 2001 was not as it is today. TME was not recommended in your Australian guidelines until 2005. Probably surgeons were doing it, but I don't know that they were all doing it. Histopathology from that trial, there's no data on the circumferential resection margin, no central review, no information on the number of nodes. So how can I relate that data to what I do with MRIs, good quality surgery in my MDT today? I can't. But I do take the message that local recurrence in the very low cancers, there was a difference between the short course and the long course chemoradiation, with a much higher risk of a local recurrence for those very low cancers, where we know that you have a much higher risk of perforations and positive resection margins there. So I take the point that low rectal cancer is probably different, and certainly, I don't know, we don't have a Gina Brown in my MDT, but we find that the MRI is much more difficult to interpret in those low rectal cancers, because at the level of the levators, it's very hard to predict whether you've got involvement of the levators or not. So I'm going to park low rectal cancer, because I don't think the arguments really quite stand up there. But I'm going to focus on 4 to 12 centimeters above the anal margin. In principle, 75% of cancers are T3, but all T3 are not created equal. It's a bit like George Orwell and Animal Farm, that some T3s are bad and some T3s are not so bad. So we know from the Mercury study that you can predict that on MRI, and you can predict that with great accuracy to 0.5 millimeters tolerance. That's an extraordinarily accurate way of being able to predict that. So how many of you, can I just have a show of hands, how many of you actually, either in your MRIs predicting or in your pathology, actually call the subdivisions of T3, i.e. 1 millimeter, 1 to 5 millimeters, 5 to 15? How many of you in your MDTs call that? Yes, there's about half of you that are already doing that. Because it is important. It's important not only in terms of survival. This is data from Erlangen from looking at T3s and dividing them into 5 millimeters or more or less, and that's irrespective of your nodal status. There is a big difference in outcomes for those patients. And when you look at things like the CRS7 trial, if you look down the bottom there, T3A, that's only 1 millimeter, up to 1 millimeter extension, which I don't think in the majority of your MRIs can actually distinguish between T2 and T3A. And the radiologists always in our unit say, it's a T2, T3, stroke, T3. So I don't think you can really distinguish those. But again, the local recurrence rate is very low for those patients. Historically, in the CRS7 trial, without MRI, without good surgery, the risks of T3B and T3C were higher, but actually I think the T3B is reasonably acceptable, and when you think that there's no MRI and only 50% getting good quality surgery, I think you could discount that. So, preoperative short course and chemoradiation do not benefit all patients. Upper and middle rectal cancer are probably more affected by that than the low, and there's no impact on disease-free survival or overall survival. I'm impressed by this data, which again is data which is 5 to 15 centimeters above the anal margin. So it's not the very low rectal cancers. But this shows a very good cutoff for about 2 millimeters in terms of your outcomes, in terms of local recurrence from population data. So I don't understand why, lots of people say, well, we need to shrink the tumor. I don't understand why response actually matters unless the tumor is borderline, unless you've gone up to the mesorectal fascia or beyond the mesorectal fascia, or you've got something outside the mesorectal fascia, or you're less or close to that, or you're maybe radioresistant, or you wish to perform a lesser operation, as we talked yesterday. So if you want to do sphincter sparing, okay, I don't think it happens, but if you wanted to, that will be a rationale for it. Or if you wanted to do a local excision, shrinkage would be a rationale for it. Or if, as Habragama is here, if you wanted to avoid surgery altogether, that's a rationale. But other than that, I don't see the issue about what making something smaller does. What is that? How is that meaningful to the patient? So, in conclusion, I don't think there is any need for chemoradiation, with the provisos that your MRI does not show disease close to or outside the mesorectal fascia, and with the proviso that you are doing MRIs, and with the proviso that you are doing good MRIs, and with the proviso that your surgeon is doing good surgery, I don't think you need tumors above the peritoneal reflection. I see a few faces actually don't like that one so much as the first one. But I don't think patients with T3 or T3B in the mid-upper rectal cancer above 4 centimeters need chemoradiation. And I don't think patients with a circumferential resection margin of more than 2 millimeters in the mid and upper rectum need chemoradiation. And none of those patients in my unit get neoadjuvant chemoradiation currently. Thank you.